I'm Jim Mold, and I am speaking today with Dr. Mary Tinetti. Dr. Tinetti is one of the leading advocates for goal-oriented care in the United States. She's developed a specific model called patient priorities care, and I'm anxious to learn more about what's happening with that these days. It's been about 5 years, I think, since we last talked during the COVID pandemic. Mary is the Gladys Phillips Crowfoot Professor of Medicine and Emeritus Chief of the Geriatrics Division at Yale University School of Medicine. Um, thank you for coming today and speaking with me. Appreciate
Good
it.
to be here.
Good. Can you, I don't think we've ever talked about how you arrived at the idea of goal-oriented care. I know I first was aware of your interest in it when with the New England Journal article in 2012, but I'm sure there was a lot of work that went in before that. Can you give me a little history?
Sure. Mainly compelled by my clinical work. I've been a geriatrician for over 40 years now, and the vast majority of my patients that I've cared for, as does anyone who cares for older adults, have multiple chronic conditions and quite variable life circumstances. And as a result of the multiple chronic conditions, a couple of things. Number one is the usual disease approach doesn't always work. Less benefit from some of the interventions, potential harm and burden. And most importantly, as your work has shown and others, is that people vary. The more conditions you have, the more you're variable in what really matters most to you about your health and your health care. And it was really my clinical lens that got me particularly interested in this work. It was probably around 2013, 2014, Amy Berman from the John A. Hartford Foundation approached me to ask if I would be interested in working with them on an approach to care that really got primary care and hospitalists more on the same page and more integrated in their care of older adults. So it was my clinical interest and the outreach from the foundation that led to myself and a group of others developing what we call patient priorities care.
Tell us a little bit about what that model looks like.
Yeah, so we developed the model with input from patients themselves, older adults, their caregivers, health professionals of all type. And what we wanted to do was, again, figure out what is the healthcare outcomes that people are most interested particularly in the face of all the trade-offs that older adults face in their care, and also their healthcare preferences, what they're willing and able to do. So our approach is to help older adults identify their health care priorities in a way that is specific and actionable enough to make decisions based on. And the components that we've identified, again, based on input from older adults themselves as well as their health professionals. We start with values because values seem to be stable over time and as health changes, but they're too vague. They may be, I want to connect with my family. I want to be more productive in my work. They're stable, but they change over time and are too vague to really make decisions based on. So we have to translate those general values into what we call goals. And goals are specific actions that reflect their general values. So if somebody's value, for example, was to connect better with their families, their specific goal might be, I want to be able to babysit my grandchildren 3 times a week while my daughter works. So those were sort of where we start, but to align the care, you also need to know about their care preferences, whether the medications, health visits, encounters are something they're able and willing to do, etc. Finally, we realized that there's so much going on that to really get started in this approach to decision making, we have to help older adults identify the health problem or the major barrier to their goals, and that will be called their top priority. So for someone who wanted to babysit 3 times a week, she might say that I'm too tired from all my medications and all my healthcare visits that I just don't have the energy to babysit. So her health priorities may be to be less tired and fatigued so that I could babysit. And from that, we can then train healthcare professionals of all time to consider all the factors that may be contributing to her inability to babysit and to be so tired, and to consider both the medical and non-medical interventions that may help her achieve her own particular goals. So everything aims at what matters most to that individual in a way that can inform decision making.
And I think an interesting to me aspect of this is that the doctor doesn't do the initial interview. The initial interview is done by a non-physician, and then the information is transmitted to the doctor. Is that correct?
Well, actually, we've really developed to be very flexible, realizing that the way people practice in today's medicine is variable. Many physicians are part of a team, and they work together, but they have different responsibilities. And so the identification of the priorities can be any member of the healthcare team that's trained and knows how to do it. Maybe a medical assistant, and maybe a social worker. It could be the physician. It could be a nurse. We also have developed myhealthpriorities.org, which is a website that older adults themselves, with a care partner, if they're interested, identify their own health priorities and print it out and bring that template to the.
That's great. I didn't know about that. That's a new development since we talked.
Yes. And that's has had some success, as you can imagine. There's still a lot of barriers to people being able to do it, to bring it in, for the clinicians to be knowing what to do with it. But we've definitely made some progress.
Yeah. And I'm sure I know that from talking to you before and from my own experience, I'm sure you've learned some lessons along the way. Can you think of some important lessons that you've learned that might help other people get there faster?
Yeah. So I've learned several things, some more painfully than others. I've learned that goal-centered care is both easier and more difficult. It's easier than once people get that aha, they recognize, okay, this makes perfect sense. We should be doing it. So trying to convince both older adults or patients of any type and clinicians that it's important, I think, has gotten easier over time. What the barrier is probably exactly what Jim you've encountered in your work, is that healthcare in general has gotten so much more fragmented, so much more complex, so much more driven by algorithms and outside forces, that finding time to incorporate it, even something they realize how important it is really, really difficult. The electronic health record is a barrier. There's what was developed to help transmit information has really made it even more difficult for people to find a place in that EHR for something like this to live, and for everybody to look at it. So I think that's really been, our major barrier is just the time and the complexity of the healthcare system that's not getting easier.
But despite that, you have, I looked on your website, it looks like people are trying to implement this all over the country. Would you say that's true?
That's true. I think we do have people also in other countries as well. We have people that once people try it, they get really passionate about it. There are people, some healthcare sites are a little bit easier because it already is focused on where interdisciplinary teams already work well together. It seems to work better. And I don't know if you're familiar with the PACE program, the program for all-inclusive care for the elderly, has been particularly successful. Even there are barriers, but it's a place where people recognize it. The VA, we have people doing it in the VA, and again, that's an integrated healthcare system, which lends itself more to having the time and the interest in doing this. But we also have we have not just physicians. We have not just primary care physicians, but many specialists as well, and physical therapists, occupational therapists, social workers, clinicians of all types. So yes, we're kind of, I think, in our sort of snowballing phase where we train now, just direct training. We probably train about 300 or 400 people a year, but we have many more people doing that training through both the American College of Physicians online, as well as now more recently with the American Association for Nurse Practitioners. As you know, nurse practitioners are increasingly becoming the primary care providers in this country. And so we're probably training thousands, now training in the thousands, mostly people doing it on their own now.
So we're both geriatricians, but I spent most of my career as a family physician, caring for people of all ages. I wonder what your thoughts, your approach is focused on a very specific group of older people, at least it was last time I talked to you. What do you see the future looking like for goal-oriented care? Do you think it applies to everyone, as I do, or
Right. I think it applies to everyone. I started with this particular group of people, number one, because as a geriatrician, most of the people I do take care of are the more complicated older adults. So that's where I started. But also, we figured that was perhaps a more low-hanging fruit because these patients were so complicated, and there was clearly uncertainty. There was so much uncertainty and burden in their care that this might be a population to start with, but with the idea that goal-oriented care should be what everybody is receiving. And indeed, we have, we don't, even patient priorities care is no longer limited just to older adults. We have people, a lot of people in the behavioral health space have also rallied around this approach to care, but it should be what everybody gets.
I'm glad to hear you say that. What do you see as your next steps in your involvement with this?
So I'm gradually moving towards retirement. And so what's been really heartening to me is so many young health professionals, again, not just physicians, but others as well, are taking it up and increasingly having leadership roles. So we have people leading the trainings throughout health professions, other people we're actually working and using AI, artificial intelligence, both to help guide the identification of health priorities, which is kind of sad that some of the chatbots actually are showing more empathy than humans. I don't know if you've been looking at that research, it's kind of sad. But so we're working at incorporating that. Also using AI as a way to help identify the care that's aligned with people's goals. When there's so much going on, there's so many factors contributing to the problem, that sometimes using AI to sort of go through the person's electronic health record, knowing what's going on with them both in their health and in their life, can at least make some suggestions for the clinician and patient to work together to come up with a good care plan. We're also using this for now discrete decisions. And surgeons have actually identified with this as well, because they have a lot of older adults or complex patients where it's not clear what the benefits of surgery are. And so I think that's worked well. But mainly the next year or so is going to be disseminating this as broadly as possible in training programs and health systems, and hopefully leave a large number of people behind me, who will carry it forward. It's going to take years and decades, I think, for it to really spread.
I'm so impressed with what you've done, though. I mean, I've been much less successful at disseminating the concepts and the methods than you have. I'm so impressed, and I'm glad that you're continuing to train younger people to take over as you reach retirement. I doubt I don't know what your plans are, but I'm retired supposedly. So hopefully you'll still have some involvement.
Oh yes, I'm not going to give it up completely.
Thank you so much, Mary, for talking with me.
Well, thank you for being interested, and good luck for you carrying it forward and carrying the word forward. You certainly were one of the founders of this area, so we all we all admire what you've done.
Thank you.